Hello dear friends, welcome once again to this 13th edition of JPEF. And this year we have three historical launches in this meeting. And one is Wegovy, the path-breaking innovation for the treatment of obesity. And number two is Libre 2 Plus, the next generation continuous glucose monitoring device. And the third is the one which is getting launched now, and that is Cybrava, Inclisiran. It is again a path-breaking innovation. It is a small interfering RNA, and this inhibits PCSK9 inhibitors, lowering the LDL and also minimizing the LDL variability. And we have three eminent speakers, cardiologists, Dr. Koshy, Dr. Praveen, and Dr. Navin. And this is a historical moment for all of you. And please enjoy. Thank you.
Listen to the inhalational therapy for diabetes. It's a new thing. Similarly, we have very exciting thing in lipidology coming up. So the title is Changing Paradigms in Lipid Lowering. I am Dr. Koshy. We have Dr. Praveen SV, Senior Consultant in KIMS Hospital. And we have Dr. Bhupen, Navinchandra Desai, Senior Consultant from Mumbai, Consultant Cardiologist. So just an introduction, we should understand that atherosclerosis is a slowly progressive disease. We used to believe it is degenerative, partly right, but it is inflammatory as well. And ASCVD, the atherosclerotic cardiovascular disease event, is acute. Never forget that. Atherosclerosis develops over a long span of time. You have the fatty streaks, the fibrous plaques, slowly the plaques build up, and then the plaque becomes unstable, you have a coronary event, or you have a stroke. So we have a long window of opportunity for containing this disease rather than, acting when the event has really happened. And we know that the most important etiological factor which leads to atherosclerosis is LDL cholesterol. All other factors are important. We have diabetes, hypertension, smoking, everything. But we should remember that ultimately it is the LDL cholesterol which gets into the vessel wall, which leads to the formation of plaque and atherosclerosis. I always tell people that you are worried about cholesterol not because it is circulating in the blood. If it remains in the blood, it is fine. But the point is, it will get into your vessel wall and you will have plaque. And aggressive LDL reduction is the important point in containing this disease. And each milligram reduction in LDL cholesterol reduces CAD by 1%. And this concept is again very important, the cumulative LDL cholesterol burden. This is similar to the smoking. We tell about the smoking years, the number of cigarettes smoked into number of years which you have smoked. Similarly, what is your LDL and how long it remained elevated? For example, you take people with homozygous familial hypercholesterolemia. They are born with an LDL of 400, 500. So they develop a heart attack by the age of 8, 10 and all that, and they die. And people believe something like 6,000 is a threshold. So if your cholesterol, LDL cholesterol is 100, you reach that threshold in 60 years. If your LDL is 200, you reach that threshold in 30 years. If your LDL is 60, you never reach that threshold in your lifetime. So LDL cholesterol is important and we should target that. I think that is just an introduction. And people have realized that. The first study in 1994, we know the Forest trial, and over the years, the LDL has come down. The LDL threshold has come down steadily from something like 190, came down to 130, 100, 70, 55, we don't know. So that is a point. So before we start, we should have some idea as to what is the currently available treatment for lowering the LDL. Just remember this is interesting. Moderate intensity statin reduce LDL by 30%. High intensity statin 50%. If you combine high intensity statin with ezetimibe, you can reduce LDL by 65%. PCSK9 inhibitor and Inclisiran alone can reduce LDL by 50 to 60%. Now, if you combine these drugs together, like a PCSK9 inhibitor with high-intensity statin with ezetimibe, you can reduce LDL by 85%. And the new drug, Inclisiran with statin, you reduce LDL by 80%. So now we know the issue is LDL, and we have very powerful tools available with us for reducing the LDL. And the new concept. With that background, let us start the discussion. We have very experienced cardiologists there. So let me start with the first question. How low would you go with respect to the target LDL cholesterol level for your very high-risk ASCVD patients? When you tell very high-risk, meaning a post-MI patient or someone with multiple infarct, polyvascular disease. So what should be the goal of LDL? Dr. Bhupen, please. Very experienced person who has been treating CAD for years together. Please go ahead.
Yeah, I think it was a very nice presentation, sir. Opening remarks were very good. As per the current guidelines for the very high-risk ASCVD patients, if you are a European, it is less than 55 milligram per deciliter. If you are Indian, it is Lipid Association of India guidelines is less than 50. But I would still go further down. He has shown that lower is better. So in a patient who has suffered a myocardial infarction, patient who has undergone angioplasty or bypass or something, if you are an Indian, you should target it to less than 50 milligram per deciliter.
Dr. Praveen, what do you think? What is your target?
Yeah, I do agree with the previous speakers. How much ever low you can go, that is always better as things stand today. And for us, high-risk patient is always, very often as a cardiologist, our high-risk patient is somebody who has multiple interventions or who comes with recurrent ACS, multiple times you need to revascularize him either by PCA, even redo CABG, all this fit in the high-risk group. And to be telling you such a general diabetic audience, coronary artery disease, multiple risk factors, recurrent ACS, it's not at all uncommon. We saw very commonly in our clinical practice. So for us, I do agree with the previous speaker, our LDL level should be somewhere 50 or below 50. And we try to achieve that target by whichever means possible in the majority of cases.
So 55 milligram will be reasonable? Yes, Dr. Bhupen.
No, I think what he said is absolutely correct. There is another entity given by this Lipid Association of India. It's called extremely high-risk category patients. So for extremely high-risk category, which is much more serious than the very high-risk patients, this very high-risk ACD patient who are on, you have achieved a target of less than 50 and still he suffers a second episode despite controlling your LDL, then you should bring it to as low as 30 milligram per deciliter. As what Dr. Koshy was rightly saying, lowest is better. So for a very high risk, less than 50, and extremely high risk, less than 30.
Okay, I think that is what the guideline tells also. This is the ESC, the European Society of Cardiology 2023 guideline in acute coronary syndrome. Acute coronary syndrome, there's no controversy, initiate high-intensity statin. High-intensity statin meaning 80 milligram atorvastatin or 40 milligram rosuvastatin. And the threshold which they have kept is 55 milligram. And if it cannot be achieved, as the second add-on drug, it should be ezetimibe. And the third add-on drug will be PCSK9 inhibitor, evolocumab. That is the current recommendation of the ESC. High-intensity statin, ezetimibe, followed by PCSK9 inhibitor, evolocumab. So ultimately, you should have an LDL below 55. And how frequently it should be checked, the ESC guideline tells check after 4 to 6 weeks, again after 4 to 6 weeks. It's a little slow, but the Indian guideline, we are a little more aggressive. That is the CSI, the Cardiological Society of India 2024 guideline. This guideline is very important. In acute coronary syndrome, it should be a combination therapy. You should give a combination of 80 milligram atorvastatin with 10 milligram ezetimibe, or 40 milligram rosuvastatin with 10 milligram of ezetimibe, irrespective of the lipid profile, in all patients. And again, you should aim at an LDL below 55. So combination therapy is the current recommendation in acute coronary syndrome in the Indian context. So we'll tell about triple loading: aspirin loading, clopidogrel or ticagrelor loading. Third loading, we are telling statin. It should be a statin with ezetimibe. What is your comment, Dr. Bhupen? You agree to that?
I fully agree with you, sir. I fully agree with you.
Okay.
All our emergency doctors have been primed. They will, as soon as a patient with acute coronary syndrome comes to the casualty, he will receive aspirin, he will receive clopidogrel or ticagrelor, plus he will receive high intensity statin also.
Dr. Praveen, you also agree to that? It should be a combination?
Yes, always. No doubts regarding the
Okay.
high intensity statin and loading dose.
Okay. And the other point is, in India we feel that the lipid profile should be checked after 4 weeks. You don't wait too long. So bring down the LDL fast. You don't wait too long. I think that concept again is important. So that is the next question. How soon do you recommend escalation of lipid lowering therapy in your post-ACS patients? What do you think, Dr. Praveen?
So, two things I'll just try to add here. One of the things is we still often find that people wait for a fasting lipid profile. No need for that. As soon as the patient is in the hospital with an ACS, take the first prick along with the troponin, you take for a random lipid profile. That is enough for treatment. Now, the aim of treatment is you should bring down the LDL as low and as fast as possible. So there what you should do is you load with 80 milligrams of atorvastatin plus ezetimibe in cases where needed, and then you recheck your lipid profiles after 4 to 6 weeks. If you have not reached your target of lipid profile within 4 to 6 weeks, it is time to intervene, add on another molecule as the situation demands. So definitely initial at presentation, the next one at 4 to 6 weeks. That is what we generally follow in our clinical practice.
Dr. Bhupati, what will be your sequencing? So first you are telling it is high intensity statin with ezetimibe. What will be your third add-on drug?
In India, I think I'm slightly, I check it after 4 weeks. As soon as a patient comes to me, we check, as he rightly pointed out, there is no need to wait for fasting. You can check it at the time when he comes to the hospital. And regardless of lipid level, give him high intensity statin and ezetimibe from day 1. I check it after 4 weeks, and now we have oral drug available in India, bempedoic acid. So my practice, after 4 weeks, if lipids are not up to the level that is less than 55 or 50, then third drug I prefer to give is bempedoic acid, because it is orally available, no injections, and it is not very expensive.
And cheaper.
Another 4 weeks I'll check, and if it is still not well controlled, then maybe I'll give PCSK9 inhibitor or Inclisiran.
But suppose a patient can afford evolocumab or Inclisiran, will you prefer it over bempedoic acid as the third add-on drug?
Yes, if patient can afford it, definitely I'll prefer it. Yes.
Okay.
But
Okay, right.
more than affordability, patients are afraid of injection.
Okay, right. And I think it's important what Dr. Praveen told. When you check the lipid profile, it is not necessary that you should do it in the fasting stage. Because blood sugar, do you think only fasting blood sugar is important? Postprandial blood sugar is probably more important because it's related to the cardiac events. Similarly, postprandial change in lipid profile is probably more important. You are concerned about postprandial increase. So never insist on fasting lipid profile. Random lipid profile is good enough. Many people do not check the lipid profile because you tell them to do fasting. Then they will ask, is it 8 hours fasting, 10 hours fasting, or 12 hours fasting? You tell them you can do it non-fasting, so the problem is settled. That again is very important. Now the risk of recurrent events in ACS patients is very interesting. You do a PCI, In the first 90 days is the critical period. That is the time they develop a new problem. So 1 in 10 patients reported a second MI, a stroke or cardiovascular death within the first 100 days after experiencing an MI. So can you wait for 100 days? No. So you should act very fast and you should bring down the LDL to an acceptable level at the earliest possible time. So you should use a powerful drug which acts very fast and brings down the LDL to the level which we mentioned, whether you are aiming at 55 milligram or otherwise. That I think is a new concept which is coming. It is not only lower but faster. Okay, that is again the same thing. ACS patients are at a higher risk of future event, and guidelines recognize that early intervention is critical to improving the outcome. That is why we tell that when a patient is admitted with acute coronary syndrome, you draw blood, check the lipid profile, but your treatment is based on the lipid profile. So everyone, irrespective of the lipid profile, should be given high-intensity statin with ezetimibe. The concept is, even if your cholesterol is only 150, even if your HDL is only 90, that is high for you. Because your endothelium is abnormal and your LDL is getting into your vessel wall and plaques are formed. So whatever be your basal LDL, it should be brought down by at least 50%. So it's not important. The treatment is not based on the lipid profile. You draw blood to find out how things are. And then you can have the target. How many drugs are required to bring it down to below 55 milligram or below 45 milligram, depending upon the risk profile of the patient. Okay, this is, this I think I will skip. Just, emphasizing the point that many of the expensive treatments like Inclisiran or Evolocumab may be covered by insurance if it is given in the acute phase in the hospital. But that's again important from a financial angle. A patient is admitted with heart attack. The LDL is high. If you have a treatment which is evidence-based, which is recommended by the academic bodies to be administered in the CCU, the insurance may pay for that, but may not be later. Okay, that's just one point. Okay, now we will go to a third point. How do novel therapies like Inclisiran fit in the current lipid lowering space? Dr. Bhupen, what do you think? Because the place of statin is very clear. The place of ezetimibe is very clear. Bempedoic acid, okay, plus minus, but people use it because it is cheap. But at the same time, we are a little worried about elevating uric acid, tendon rupture, and things like that. Evolocumab is trying to find its place. Now, where will you place Inclisiran?
If patient can afford, I would definitely like to use Inclisiran much more earlier. Because as you rightly showed in one of your slides, first 100 days are very important. 10% of patient, you have done a great angioplasty, patient is doing very well, he goes home, and within 90 days or 100 days comes back with another MI, or stroke, or even death. So why to wait for it? Even if you give high dose of statins, you will not be able to achieve more than 50% reduction. So to begin with, if your LDL is 170 or 180, you will never be able to reach the target. You will need to take the help of ezetimibe, which is again a very mild drug, I would say. So if patient can afford, I will definitely give Inclisiran much more earlier. I would not wait till he develops second event.
Dr. Praveen, would you consider Inclisiran inside the CCU for an acute coronary syndrome?
I would broadly say that I have given these sort of injectable cholesterol lowering medicines for acute coronary syndrome in the CCU. In patients whom I have found it's an ACS post-intervention, especially somebody who has an ACS at a young age. Say, for example, I'll say with a case study. I had a 43-year-old female, no other known risk factors, acute MI, inferior wall MI, LDLs 160. I do a primary PCI. I have started on high intensity statin, but the next day I gave the first dose of injectable cholesterol lowering agent. So my bias is now generally towards giving these drugs in patients who have a high risk ACS, even in the ICU, a high risk population with high lipid levels, and whom I want to reduce the lipids to the lowest possible in the fastest possible time. And again, as I adding to Sir's comment, always my bias is towards giving these sort of injectable lowering medicines in patients who can afford and high risk patients. So somebody who can afford these medications I have given, and of course I found it very useful. So my bias is always towards these molecules, provided the finances permit that.
In fact, we do have some data of evolocumab inside the CCU in acute coronary syndrome, stating that it helps. Similar data is emerging with Inclisiran also, but it may perhaps take some time. But good to consider that concept is good.
Can I add one comment if you
Oh,
don't?
please, go ahead.
So the advantage with evolocumab is it produces a faster reduction in LDL. You see notable reductions in LDL in short span of around 7 to 14 days.
Correct.
Whereas in the case of Inclisiran, you need
Takes longer time.
bit of
Takes
a longer time.
But the main issue with evolocumab is it has to be given more frequently. Ideally once in 2 weeks or at least once in a month. And then it comes to be a little more expensive compared to Inclisiran, whereas the main advantage of Inclisiran is it need be given only twice a year. That is the main advantage. This I think you have seen already. The first and only siRNA, small interfering RNA therapy for effective LDL reduction that you saw in the video, so I am skipping it. So this is the important point. Statin has to be taken every day. 40. At that point, probably, it's not supported by a lot of data, but it looks sensible to incorporate a newer drug for further LDL lowering. Because this is something you can target very easily. So this is endorsed by all the guidelines. So Inclisiran guideline recommended lipid lowering therapy in ASCVD patients not achieving the LDL cholesterol goal. So the goal is 55 milligram. So if that is not achieved, you can certainly consider Inclisiran. And finally, I think before we conclude, which ASCVD patient types do you think would most benefit from a novel therapy like Inclisiran? In fact, Dr. Praveen partially mentioned that in his previous point. Dr. Bhupen, you be very specific as to which type of patients you would consider Inclisiran, very specifically. Now you have a lot of options, not like previous years, a lot of options available for lipid modification.
So I'll be very aggressive if patient has atherosclerotic cardiovascular disease. Any patient, each and every patient who has not achieved LDL level of less than 50, despite the usual care, they will become a de facto indication for Inclisiran injection.
Okay. And what about statin intolerance?
For them, you have to give it, sir. For them, this becomes the first drug. Those who cannot tolerate statin, you give it as, because we want to reduce LDL as fast as possible and as low as possible.
Young patient but non-compliant but has enough money?
Yeah, that is another indication. Patients who are lot of money but not compliant, then you can convince what sir said, that these are like vaccines. You have to take twice a year, you have to take a shot.
Lot of traveling today in India, tomorrow in New York, next week in Tokyo, that type of patients.
High-flying young executives.
On the move all the time.
Yeah, and they accept it.
Attending conferences.
You tell them you don't have to take medicines every day, just take one shot in a 6 months' time. Many of them will accept.
Okay. Dr. Praveen, what is your take on that?
So practically, I would rephrase the question like whom I would suggest Inclisiran, because not everybody will agree to that. So the first, this thing is somebody who is intolerant to statin. Of course, definitely no doubts about that. Second group of patients, as Dr. George rightly said, somebody who has very high levels of LDL, who is like not very keen to take a tablet every other day. And I have given that also. For example, I have told one patient, he said he has an insurance abroad which covers Inclisiran. He is now on that, of course not from India, because he is a traveling person, as George sir rightly put. The third group of patient is somebody whom I have given a statin. His lipids have not come down. He is a high-risk atherosclerotic disease or post-CAD patient. These patients I would definitely suggest if the LDLs are not coming down. So these are the broad, and of course definitely somebody who has very high levels of lipids. I think clinically it is a heterozygous one with strong family history of CAD and all. I definitely suggest these sort of medications. These are the broad patient categories whom I would...
I think that is summarized there. Young male patient with first MI misses medication due to hectic work schedule, frequent travel. Middle-aged male patient with complex PCI often forgets meditation due to multiple prescription. And elderly female patient with recurrent event in whom you have to target a low LDL, finds it difficult to adhere to medication due to polypharmacy. And as was mentioned, this is a drug which has some effect on the lipoprotein little a. We know that safe limit of lipoprotein little a will be below 30 milligram. Above 50 is very bad. 30 to 50 will be sort of intermediate. So that probably is one soft indication. So approach consideration based on the ESC 2023 guideline in very high risk ACS patients. That is the same thing which they have summarized. That the first case which we showed, and that is a young male patient who is non-compliant. Then the second patient, a post-PCI patient. Third, elderly patient who is likely to forget the medication, and all those things. So I think that is the specific patient profile in which you can target the Inclisiran. So treatment benefits offered by Inclisiran in very high-risk ASCVD patients. Mainly three things: more than or equal to 50% effective and more important, sustained LDL cholesterol reduction. Statin you will forget in between, so you get swing like that. This is sustained. Second, conveniences of 2 doses a year and potential to enhance adherence. Well-tolerated safety profile of up to 6 to 6.8 years. So I think with that we will conclude by stating that Inclisiran is an incredible molecule. No doubt about that. It's an incredible molecule with a lot of things in the pipeline. Now I think we have around 6 minutes for discussion. We will be happy to have any comments. Any questions to be clarified?
LDL, yeah, not, no, it reduces triglyceride. No, it is not primarily indicated for hypertriglyceridemia, but it definitely reduces triglyceride to some extent. But this is primarily not a drug for elevated triglyceride. Primarily, this is a drug for LDL reduction.
Sir, other than what drug we can use for the triglyceridemia? Sir, what is the role of fibrates in the picture of dyslipidemia?
You can use fenofibrate if your triglyceride is very high. If it is diabetic, maybe you can use saroglitazar. Maybe you can use those fish oil combinations. Now there is a drug available for it.
Thank you for the good presentation.
After the LDL, we should go for the non-HDL, not the triglyceride. And for triglyceride, we should not use fibrates if it's less than 500. If it's more than 500, you have to add fibrates. Otherwise, you should go for the highest dose of statin. You can add ezetimibe to it, and that brings down the triglyceride also. Only if the triglyceride more than 500, then you have to add fibrates, because otherwise there may be pancreatitis. That's the recommendation now.
Thank you for the nice presentation.
Icosapentaenoic
I have a
acid is
question
available
here.
for hypertriglyceridemia.
May I
now in the
have a
market.
question?
And there is some trial data also with icosapentaenoic acid.
Yeah. Is there any study or recommendation in type 2 myocardial infarction? Inclisiran in type 2.
See, type 2 myocardial infarction is just a terminology stating that there is a supply-demand imbalance in which, you get elevated of the cardiac biomarkers. That's just a terminology, type 2 MI. Type 2 MI, someone has sepsis, you find high troponin. Someone has anemia, you find that patient has elevated troponin or some systemic problem. So, that does not actually call for atherosclerosis management. So, whatever we are telling is actually so-called type 1 MI. Type 2 MI is just a descriptive term.
Okay, one more please. What is the current knowledge about dietary fat and serum cholesterol levels, lipid profile? Dietary fat. Do we still recommend strict fat restricted diet as a physician?
No, there is still a relation between dietary fat and blood lipids. There is no direct relation between dietary cholesterol and blood cholesterol levels. But dietary fat, more dietary fat, especially more saturated fat and more trans fat, that increases the LDL metabolism and more of LDL is produced. So no doubts about that. It's basically that dietary cholesterol does not have a one-to-one relation with the blood cholesterol levels. Dietary fat still holds.
No, I think the point is, cholesterol has an endogenous pathway and an exogenous pathway. So if you totally, eliminate cholesterol from your diet, your endogenous pathway will be accelerated. Acetyl-CoA, acetoacetyl-CoA, and these 27 steps in the cholesterol biosynthesis. Whereas if you have some cholesterol in your diet, that endogenous pathway may not be that activated. So, cutting the dietary cholesterol alone will not bring down your serum cholesterol. That I think is the message, not otherwise. Even if you totally eliminate the cholesterol and saturated fat from your diet, still your serum cholesterol can be high, depending upon your metabolic pathway. Because we all go back to our biochemistry. The acetyl-CoA is the common pathway. So acetyl-CoA, acetoacetyl-CoA, it goes like that, the cholesterol biosynthesis. So the body is capable of that. So the message is, such people require lipid lowering therapy. Dietary restriction alone will reduce cholesterol only by 10 or 15%. That's the important message.
So I fully agree with you. All these lipid lowering therapies are on top of lifestyle modification, which includes diet. And when you combine statins with ezetimibe, you take care of both the pathways, what Sir was trying to say. Endogenous pathway will be taken care by the statin, and exogenous, whatever you eat, the absorption of those lipids will be reduced by ezetimibe. Yes, madam.
Yeah, so just a few comments to be made. I come from an institute where this molecule is being used in a large number. So there are few things, but because when it was started, Inclisiran, the cardiologist had used it for lowering lipoprotein A as well. Okay, that was the initiation because my closest relative had some problem. Then it was started for that. Initially, there was fall, maybe from 95 it came to 78, but I think it has never come down below. But when we repeated it, it was the number has never come down. So I don't think in Indian scenario we have reduction to the tune of 41%, which you have said. I don't think so. Second is definitely a patient on maximum dose of statin, and even without that, beyond that, we have to reduce the LDL cholesterol to say below 15. Do you think twice a year is required this dosing? Because my brother-in-law, his LDL has now come down to 26. It is 26 now. And when we repeated after 6 months, it was still 26, 27. So do you need a second dose? Or is it proper that we give it at the end of 1 year?
Okay, I think Dr. Bhupen, what do you think?
In the sir has shown in the initial slide, lower is better, lowest is better. So even if it comes to 26 or 16, no need to reduce medicine. Continue with the same
No,
dose.
sir, what I said, if it is persistent at 26, do you need twice a year injection or one dose is enough?
Yes, you need it. If you stop it, it will start rising.
Dr. Anita, people have tried that with Evolocumab. Evolocumab is recommended once in 2 weeks or once a month.
Yeah.
But there are people who take it once in 3 months.
3 months,
because that keeps their LDL in the normal range.
Yeah.
But that is, not a recommendation. You may try it in an individual patient depending upon your clinical judgment.
If you reduce or stop medication, it will start rising again. So you will lose all the benefits. And about your question about lipoprotein A, which is a very common Indian problem.
Yeah.
I'll tell you this is slightly off-label indication. If I have a patient, I would definitely give high dose of statin plus ezetimibe in acute coronary syndromes. But at the end of 4 weeks, if I see lipids are not well controlled and lipoprotein is high, my third drug becomes Inclisiran, not the bempedoic acid or PCSK9 inhibitor. So I will modify my treatment because this is the drug which have shown reasonably good LPA reduction.
So if the LDL has come down to the maximum lower, say 20, 26, even if the patient has another cardiovascular event and he has a high lipoprotein A, what is the other choice that you give apart from all those things?
Maybe you can consider this drug as a off-label indication. As of now, this is not approved for lowering lipoprotein A. You will have to wait for some time. New drug pelacarsen is coming. Olpasiran might come, but it will take 2-3 years. But as of now, they are not indicated.
I think we have to conclude. Before we conclude, we would like to thank Dr. Jyoti Dev and team and Novartis for this kind invitation, which we all enjoyed. Thank you very much for your very nice discussion. Let us give a big hand to Dr. Bhupen and Dr. Praveen for the excellent talk and for clarifying most of our gray areas. Thank you very much. Thank you for you.
Thank you, Dr. George Koshy, Dr. V Praveen, and Dr. Bhupen Navinchandra Desai.